now what we're all here for. Today's event is about myeloproliferative neoplasms and heart health. And joining us for this event is Dr. Orly Leiva. Dr. Leiva is a cardiologist. He's an advanced heart failure and transplant fellow at the University of Chicago. And what's really unique about Dr. Leiva is he has a research interest in furthering the understanding of cardiovascular risks for those living with MPNs. And we're going to hear some of his work today and have a really cool opportunity to hear from a cardiologist who understands a little bit about the MPN world as well. So, with that, I'm going to go ahead and turn it over to you, Dr. Leva.
Awesome. Thanks for the intro. Hi everyone. My name is Orly Leiva. As mentioned, I am a current advanced heart failure, cardiac transplantation, and pulmonary hypertension fellow at the University of Chicago. Have been everywhere. Did my med school at Boston University. Did my internal medicine training at Brigham and Women's Harvard Medical School in Boston, and did my general cardiology training at NYU in New York. So kind of been everywhere. But it's my honor to kind of talk to you guys and just have a discussion about cardiovascular disease and myelofibrosis. This is a topic that I'm very interested in. I've been doing research in this field since I was a medical student. I work very closely with a lot of, uh, you know, myelofibrosis and MPN specialists, and this is something that really is special to me. So I want to start off with a few disclosures. One, I don't have any financial disclosures related to this talk. The second is I am a cardiologist, not a hematologist. So as much as I go to these, American Society of Hematology and ASCO meetings and present research at these places, clinical, expertise is in cardiology and heart failure. And so this talk is meant to be educational, not meant to be any medical advice. So talk to your doctors before making any changes. So I think this is a group I don't really need to go into too much about what myelofibrosis is, but it is a disorder of clonal proliferation of myeloid cells in the bone marrow that can lead to progressive bone marrow scarring, fibrosis, and eventual failure. And it is considered part of the myeloproliferative neoplasms or MPN group of disorders. And this can either be primary myelofibrosis or it can be secondary due to progression of other myeloproliferative neoplasms, including essential thrombocythemia or polycythemia vera. And then compared to other MPNs, myelofibrosis itself is associated with higher rates of progression to acute leukemia and other hematologic conditions as well. And so, I think it's important to kind of take a step back because I feel like when people think about myeloproliferative neoplasms, they think of this kind of chronic hematologic disorder that's mainly managed by a hematologist. But what I would like to kind of highlight is that it's a real systemic disorder that affects the whole body, and cardiovascular diseases in particular are very important when it comes to the prognosis and morbidity of patients with MPNs. So in this paper, you can see here, I kind of like highlighted, despite the fact that there's a competing risk of death due to hematologic malignancy or infection, you can see here that cardiovascular disease and cerebrovascular disease jointly account for the second highest rate of mortality in patients with myelofibrosis, and therefore it really is a kind of fertile ground for further research and understanding in order to improve outcomes because it does affect so many people with myelofibrosis. So there's a spectrum of cardiovascular diseases and MPNs, and this is just a figure from a paper we published in 2022 with Dr. Hobbs. But essentially, patients with myeloproliferative neoplasms can have several different types of cardiovascular disease. So atherosclerosis, so that is plaque buildup in blood vessel walls that can mainly affect the heart. Sometimes it can affect the blood vessels of the brain and also the blood vessels of the legs. Seems to be more common in patients with myeloproliferative neoplasms, and that can lead to arterial thromboses or blood clots in the arterial system, as well as heart attacks and heart failure as well. But then there's the other part of cardiovascular disease in MPN patients that is what I would kind of think about as non-thrombotic, and that includes congestive heart failure and pulmonary hypertension, which I will talk about in a little bit. So I'll touch briefly about thrombosis and myelofibrosis. So blood clotting is a known complication in patients with MPNs, and I think there's been a lot of research over the past decades on understanding and characterizing blood clots in patients with MPNs. And MF is not is also within this realm. However, it's been understudied in MF mainly because in later stages of myelofibrosis, you get thrombocytopenia or low platelet counts, and there's a higher risk of acute leukemia as well as high risk of bleeding. However, despite all of this, thrombosis is still a pretty important source of morbidity and mortality in patients with myelofibrosis, and something that we should keep in mind, especially in patients that don't have the low blood platelet count. So there's the prevalence about is mixed. So in a study that looked at an aggregation of several studies, something called a meta-analysis, it showed that the prevalence of thrombosis in patients with myelofibrosis was anywhere between 6.6% to 15.9%. So that means, roughly one in every 8 patients may develop a blood clot who have myelofibrosis. And this is after a median follow-up of anywhere between 2.6 to 6.2 years. And so the mitigating thrombosis risk in patients with myelofibrosis is important, especially when you have to weigh the pros and cons of the treatment of thrombosis, because on one hand, you have this pro-clotting disorder, and on the other end, the treatment of blood clots is blood thinners, and patients with myelofibrosis are also at higher risk of bleeding. So kind of mitigation risk is very important, and it's very nuanced, and I think it's still an area of active investigation of how to find that perfect balance in this patient population. So there's no randomized controlled trials of statins. So that includes like atorvastatin, rosuvastatin, or like the brand names Lipitor or Crestor. But there have been some retrospective studies that suggest that statins may be beneficial in reducing blood clots in patients with myeloproliferative neoplasms in general. However, this hasn't been studied particularly in patients with myelofibrosis, just given the relative rarity of those patients in the number of studies that are being done. Aspirin is another medication that is usually, used more in the essential thrombocythemia and polycythemia vera phenotypes of MPN. There is some evidence that in patients with prefibrotic myelofibrosis or have more of an essential thrombocythemia-like phenotype may benefit from aspirin. However, the decision of whether or not you should take a baby aspirin should be left up to you and your hematologist who have a better understanding of this. So I want to move on to essentially the meat and potatoes of my talk, and this is focusing more on the heart failure and pulmonary hypertension aspect of myelofibrosis, because as you know, I'll share some data that we've already published and are in the process of publishing that suggests that these two disorders are relatively common in myelofibrosis. They're not very well studied, and the awareness of these disorders in myelofibrosis is quite low, where many hematologists aren't aware of them, and despite how important and prevalent these conditions are. So our study, our group has suggested that the development of congestive heart failure and pulmonary hypertension are significant sources of cardiovascular morbidity and mortality in MPNs, in particular patients with myelofibrosis. So I'll start off with heart failure. So heart failure is a syndrome. It's a clinical syndrome that arises from kind of two different sources. One, and this is kind of like a gross simplification of it, and it's a little bit more complicated. But in general, there's two types of heart failure. There's a systolic dysfunction heart failure, or there's diastolic heart failure. Within the medical community, we think of it as heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, knowing that this is actually in a continuum. So heart failure can either arise from heart muscle that is weakened, and that impairs the pumping function of the heart. So the heart can't send blood to the rest of the body. And therefore, the blood kind of builds back up into the heart, and that can cause fluid retention in the lungs and the legs and the abdomen, and symptoms of heart failure. which I'll get to. And then on the other side, you can have heart failure where the heart muscle is squeezing appropriately. It's strong enough, but it's stiff and it doesn't fill as well as it should. And so blood again backs up into the lungs, into the abdomen, into the legs, and causes a lot of these symptoms. And that's what we call diastolic dysfunction, or in the actual in the medical nomenclature, is heart failure with preserved ejection fraction, or HFpEF. So the symptoms of heart failure are shortness of breath with activity, either swelling of the legs or the abdomen, shortness of breath when laying flat, or also called orthopnea, or even shortness of breath bending down to tie, like when you're tying your shoes, that's called bendopnea. And it's a little tricky, especially when patients with myelofibrosis who might have other reasons to have leg swelling, or other reasons to have abdominal fullness. For example, spleen size is important in myelofibrosis. So big spleens can kind of cause swelling of the abdomen that it may or may not be necessarily related to heart failure. So it's difficult to kind of tease these out, and that's why any patients with myelofibrosis exhibiting any symptoms should be evaluated by a cardiologist. So I took this slide from the Cleveland Clinic, and this is essentially just a visual representation of the broad spectrum of clinical features that congestive heart failure can present with, including fluid around the lungs or in the lungs, bloated stomach because of fluid within the belly, and then swollen legs. And then over time, heart failure is important in causing morbidity because it can, as the heart is damaged and doesn't pump blood appropriately, and it doesn't receive blood appropriately from the rest of the body, it can cause dysfunction of other organ systems, including the kidneys. So it can cause kidney failure. It can also cause liver failure. So heart failure is something that's very important to kind of identify early, to treat it early, and kind of reduce the risk of other complications from it. So now the question now is, how does heart failure tie in with myelofibrosis? And before we looked at it in our research group, there actually really wasn't that much information about myelofibrosis. And I think within the past couple of years, we've been shedding a little bit of light about what's going on with heart failure and what the connection is between heart failure and myelofibrosis. There are prior studies that look at Medicare and Medicaid data sets that suggest that patients with MPN in general are a higher risk of heart failure compared to the general population. And one estimate is about a twofold increased risk of developing heart failure in patients with MPN. But as our studies and other studies have shown, that among patients with MPN, it's actually those with myelofibrosis that are particularly at the highest risk of heart failure. And so this is from a paper that is currently under review, and we hope to publish soon. And essentially, we took about 500 patients from two big academic centers who had ultrasounds of the heart, and we kind of followed them to see who developed heart failure. So in our cohort of 500 patients, about 86 patients developed heart failure, and then we looked to see if there's any risk factors associated with the development of heart failure. And so heart failure is associated with a lot of cardiovascular diseases and risk factors such as diabetes, high blood pressure, obesity, and the standard things that are bad for the heart. And what we found is that's also the case in myelofibrosis and myeloproliferative neoplasm. So those patients that had diabetes had a twofold increase of risk of developing heart failure. Patients that had prior atherosclerosis, so prior known coronary disease, prior strokes, prior heart attacks, have a twofold increased risk. We use this echocardiographic finding called the EDA, and that was strongly associated, as well as left ventricular hypertrophy. So like the bigger, thicker the heart muscle was on the ultrasound of the heart, that also correlates with a higher risk of heart failure. So the things in the blue are not groundbreaking or unique to myelofibrosis, and actually these are very known and common risk factors for heart failure in the general population. However, we also looked at things that are specific to the MPN patient population. And what we found was something very interesting. So it seems that patients that have a more proliferative or more advanced form of myeloproliferative neoplasms tended to be at the highest risk of developing heart failure. So patients with high white blood count at the time of the first echo that were at the time when we enrolled them in the study was associated with increased risk of heart failure, as well as spleen size, with large spleens having much higher those patients with larger spleens have a higher risk of developing heart failure compared to patients with smaller spleens. And I just want to make a note. This is all kind of retrospective and at this point hypothesis generating. So this obviously all these findings need to be kind of proved in the gold standard of the randomized clinical trial, and more of a prospective study. However, with that caveat, our team also found that treatment with ruxolitinib, or a JAK inhibitor, was associated with a lower risk of heart failure. And so that's definitely very important to note, and we hope that further study and if ruxolitinib really does reduce the risk of heart failure, can be done. Um, and so what we found was that not only does heart failure hospitalizations cause decreased survival. So on the right here you can see we have something called a survival curve, where on the y-axis it's what the probability of survival is at any given time point on an x-axis, which is months from the enrolling echo. And as you can see, patients that with myeloproliferative neoplasms who've had a heart failure hospitalization are at higher risk of death compared to patients who never had a heart failure hospitalization. But what was interesting was when we looked at patients with polycythemia vera and essential thrombocythemia, it's the patients that had heart failure that ended up developing or being diagnosed with secondary myelofibrosis. And this suggests that a heart failure hospitalization it should be a warning flag to hematologists to kind of be on the lookout for disease progression in patients with myeloproliferative neoplasms. And so again, this is just like a 30,000-foot view of the study that we hope to publish. So among the whole cohort, we found about 17% of patients had a heart failure hospitalization. And among patients with heart failure hospitalization, a whopping 65% of them had something we call major adverse cardiovascular events. So that's any recurrent hospitalization for heart failure, or a heart attack or stroke, or death due to cardiovascular diseases. So once you develop heart failure, the rates of having worse cardiovascular diseases occur are higher. And what we also found was that among patients with heart failure, those that were treated with ruxolitinib were less likely to experience a second hit of heart failure or other kind of adverse cardiovascular event. Again, this is all hypothesis generating. We hope it spurs further research in this, but it's something that is important to kind of note, especially since there's not much data in the literature. And then moving forward, now that let's take a step back and say, let's look at all patients with MPN who have who developed heart failure. Uh, does having myelofibrosis change the risk after having a heart failure hospitalization? So in order to ask that question, we used a at-large administrative data set that encompasses about 50% of all hospitalizations in the United States. And we looked at patients who had a hospitalization for heart failure who had myeloproliferative neoplasms, and then we identified those patients that had ET or PV, or in those patients that had MF, and kind of compared them. And we did this fancy, statistical methods to kind of try to account for all the differences and all the confounders and all the variables that might differ between these two patient populations. And after we adjusted for all the confounders, we found was patients with myelofibrosis compared with those with essential thrombocythemia or PV had higher risk of death during their hospitalization of heart failure. Again, the death rate the death rates within the first heart failure hospitalization are relatively low. In just looking at the whole population, about 5%, but those that have myelofibrosis were just at a slightly higher risk of death compared to patients with essentially with some ET or PV. And those with myelofibrosis also had higher rates of readmissions to the hospital for cardiovascular reasons, for heart failure reasons, though they had less risk of coming back to the hospital for blood clots. So that was interesting to note. And again, this is just another kind of visualization of the risk of recurrent hospitalizations for cardiovascular and heart failure reasons within 90 days of discharge for heart failure. You can see that those with myelofibrosis were at a higher risk of both heart failure and cardiovascular readmissions. So this suggests that, patients with myelofibrosis are a more vulnerable patient subset than patients with ET or PV, which themselves are a more vulnerable subset of patients compared to the general population of heart failure patients. So these are the kind of patients that, as a cardiologist, if I see someone that has this, these conditions, I'm more worried about them. I want to keep a closer eye. And I think definitely more research needs to be done to kind of mitigate this risk and try to improve outcomes, because these are very important sources of morbidity and mortality in patients with myelofibrosis. So I'll just touch base a little bit about the treatment for heart failure, and that this will be largely driven by your cardiologist and your doctors, but this is just kind of like the 30,000-foot view of how I treat heart failure as a heart failure and transplant specialist. So right off the bat, anyone with suspected heart failure should see a cardiologist. And that goes without saying that, our training allows us to manage these patients and know what to look for and know what to do. And then, if the heart failure is very advanced, to maybe a referral for a heart failure specialist is warranted, but definitely at least a cardiologist. And it's important because the prompt diagnosis and treatment of heart failure improves symptoms and also life expectancy. So heart failure is almost akin to having another cancer. So when you look at the large heart failure population, the 5-year mortality of heart failure, of anyone with heart failure, is the same as the 5-year mortality of some types of cancer. So this is a disorder that is very morbid, and it's something that needs to be taken seriously. And when you add it on top of something else like myelofibrosis, it just adds to the kind of sense of urgency, and just patients should just be watched a little bit more carefully than otherwise. And the treatment really depends on what type of heart failure. So is this a systolic or a pump function malfunction, or is it the heart is stiff? So is this half ref or half PEF? And so in the world of half ref, so that's an ejection fraction of less than 40%, we have a wide armamentarium of medications. We have what we call our 4 pillars of guideline-directed medical therapy, or GDMT, and that includes your ACE inhibitors, or angiotensin receptor and neprilysin inhibitors, such as Entresto. This includes your beta blockers, aldosterone antagonists, and SGLT2 inhibitors, plus or minus any device therapies that might be indicated, including a defibrillator or a pacemaker. And as you can see, there's a lot of things that can be done and have been shown to improve survival and symptoms in patients with heart failure with reduced ejection fraction. And then for treatment for HFpEF, it's a little bit less clear. There's water pills or diuretics for managing fluid buildup and helps with symptoms. There's a weak recommendation by the guidelines for aldosterone antagonists and SGLT2 inhibitors. And for patients with HFpEF that is more of an obesity metabolic phenotype, the GLP-1 agonists have been studied and shown some good promise in HFpEF, but there's just not as much tools in our armamentarium for HFpEF. And what's interesting, and I didn't put in these slides, is when we looked at patients with myeloproliferative neoplasms compared to the general population, the rates of patients with HFpEF were higher in patients with myeloproliferative neoplasms than patients with without myeloproliferative neoplasms. This suggests that there's maybe a different pathophysiology associated with heart failure with MPNs that is yet to be kind of fully disentangled compared to the general population. And so these might be two different kind of disorders, but at least for right now, we kind of treat everyone the same. So I'm switching gears a little bit. So I'm going to be talking about pulmonary hypertension for the next little bit. So pulmonary hypertension and heart failure kind of go hand in hand. They're kind of two sides of the same coin, but it's just a little bit more nuanced for pulmonary hypertension. So um, this is all very technical, but essentially, pulmonary hypertension just means that the blood pressure inside the arteries of your lungs is high. So just as someone can have hypertension in the body, arterial hypertension, that's what your doctor checks when they put a blood pressure cuff on your arm to see what your blood pressure is. That's your systemic blood pressure. That's your arterial blood pressure. Pulmonary hypertension means that your blood pressure inside your pulmonary arteries are like the arteries coming from the heart to the lungs are high. And the way we define that is by doing a procedure called a right heart catheterization, which entails putting an IV in your neck and putting a tiny tube of plastic that has a balloon at the tip, and we float it into the heart and into the blood vessels of the lung, and we measure the blood pressure inside the heart, inside the lungs, and then we can also use that to estimate how well the heart is pumping. And we can also measure the blood pressures of both the right and the left side of the heart, although the left side is more of an indirect measurement. While right heart catheterization is necessary for the diagnosis, a less invasive test called a transthoracic echocardiogram or just an echo is the more commonly used, and it's a non-invasive screening tool. So you can get a lot of good information. You can see signs of pulmonary hypertension that may then prompt your physician to go ahead and discuss a right heart catheterization for the definitive diagnosis. But at least the echocardiograph, the echo is widely available. It's very non-invasive, and it's cheaper. Doesn't have to there's no radiation. Again, pulmonary hypertension literally just means that the blood pressure inside the heart, inside the lungs, is high, and so there's many different causes of pulmonary hypertension and many different kind of profiles. And I'll try to just go over it just to have like the basic understanding of this. But what I think you guys should walk away from is that the symptoms of pulmonary hypertension are very similar to the symptoms of heart failure. So that is shortness of breath, especially with walking. Sometimes you might have low blood oxygen, and in very, very severe cases, fainting, especially with exercise, is kind of a red flag. But the biggest, most common symptoms, it's either asymptomatic or you don't know you have it, or you have shortness of breath. And most of the time, people will have symptoms, and most of the time, the symptoms is just feeling breathless with exercise. So this is a little schematic that I like to kind of show like the medical students and residents of the heart. So the heart if essentially functions as a closed circuit. So I like to divide the heart into the right side of the heart and the left side of the heart. So the right side of the heart receives the blood from the rest of the body. The blood, that the body's already extracted all the nutrients and all the oxygen from, and exchanged it for carbon dioxide. Put the waste products of respiration in the blood, and then that everything goes to the right side of the heart. The right side of the heart then sends the blood through the pulmonary artery, through these, and as the pulmonary arteries go deeper into the lungs, they branch into smaller and smaller vessels that eventually lead to the alveoli or the air sacs of the lungs. And this is where in your body, the oxygen gets absorbed into the blood, and then your blood gets rid of all the carbon dioxide. And then you breathe all that out. And then the blood has full of oxygen, is ready to go through the body. It returns into the left side of the heart, into the left atrium, left ventricle, and then it gets ejected to the rest of the body, so that your body has a new source of oxygen and can do all the things that it needs to do. Now, this is a good way to break down the different types of pulmonary hypertension. So there are really three different big types of pulmonary hypertension because, like I said, pulmonary hypertension just means that the blood pressure inside the lungs is high, but it doesn't tell you why. And so there are the three big types. One's called precapillary. So that means that there is something kind of blocking the blood flow before it reaches the alveoli. And that is defined as you have high pulmonary vascular resistance and a low pulmonary capillary wedge pressure, which means that the high blood pressure in the lungs is not due to the left side of the heart. Because if it's the left side of the heart, then all the pressure that backs up, for example, if you have heart failure or you have valve disease, and the pressure inside side of the left side goes up, then that gets transmitted through the lungs, and then goes up in the pulmonary artery. So it's important, and that's why the right heart catheterization is vital to make this diagnosis because the treatment of pre-capillary pulmonary hypertension is vastly different than the treatment of post-capillary pulmonary hypertension. So it's important to know. On top of yeah, so this gets complicated. So so I apologize, but on top of the type of hemodynamic, there's actually also the World Health Organization groups into five different groups grouped by the cause of it. So the first is group one, which is called pulmonary arterial hypertension, which means that the tiny arteries get scarred, and that's usually a precapillary, and that there's a bunch of different things that can cause it. Um, then there's group two, which is essentially synonymous with left-sided disease, so it's a heart failure or valve disease. Group three is when the lungs themselves are bad, and then that causes the blood pressure of the lungs to go up. Group four is blood clots in the lungs that can increase the blood pressure. And then group five is this kind of mixed bag. And then classically, MPN, like pulmonary hypertension associated with MPNs, are grouped in this kind of nebulous group five, which is kind of like a grab bag. And so touch briefly about transthoracic echocardiography because this is one of the tools that we use as cardiologists to both identify heart failure and and also signs of pulmonary hypertension. So it's widely available. It's non-invasive. It uses sound waves to visualize the structures of the heart and the thoracic vessels. We can also use all these fancy Doppler echoes that uses sound waves to measure the velocity of blood flow through the heart and the blood vessels of the heart. And then that way we can actually use to estimate the pressure that we would measure with the catheterization, and we can use it as a rough estimate of what the pressures are. And one of these measures is something called tricuspid regurgitation velocity, which can be used to estimate the pulmonary artery systolic pressure. And so the higher the pressure, the more likely you are to have pulmonary hypertension. And so pulmonary hypertension is kind of this newer hot topic in myeloproliferative neoplasms. And there was really one really seminal study that was performed in 2023 by this group in France that has this large data set of pulmonary hypertension. They identified 90 patients with pulmonary hypertension who had MPNs, 42 had PV, 35 ET, and 13 had myelofibrosis, and they only included patients that had precapillary PH. What they found was interesting. So among the patients with pulmonary hypertension, the most common cause of pulmonary hypertension in patients with polycythemia vera or essential thrombocythemia was blood clots, with over half of the patients having the diagnosis of this CTEPH or chronic thromboembolic pulmonary hypertension. Um, Among patients with myelofibrosis, though, group five or idiopathic, or we don't know why, it was the most common, with 82% having group five pulmonary hypertension. And so this kind of begs the question, is pulmonary hypertension something we should be actively looking for in patients with myelofibrosis and myeloproliferative neoplasms? And I think that's the kind of the question we seek to answer. And so, there is evidence to show that pulmonary hypertension and MPNs may be a possible harbinger of disease progression. So we performed a study of looking at patients at three different academic institutions using echocardiography. And what we found was that pulmonary hypertension, at least on echo, which is not the gold standard, but it is something we use to screen, was common with about half the patients included in their study having pulmonary hypertension on the ultrasound. And those that had pulmonary hypertension were at higher risk of disease progression. So it's either ET or PV progressing to myelofibrosis, or patients with myelofibrosis progressing to leukemia. And here, this is a paper study that of a paper that's currently soon to be published. We stratified patients with either low or intermediate or high risk of having pulmonary hypertension based on echo. And what we found was that those that had intermediate or high probability of pulmonary hypertension on echo had a higher risk of progression to secondary myelofibrosis or leukemia, and also at higher risk of having major adverse cardiovascular events. So this suggests that identifying patients with intermediate or high risk of pulmonary hypertension on echo was useful in kind of predicting which patients might develop either disease progression or adverse cardiovascular events. What I would like to make note, though, is that this is also a retrospective study. So all these patients had echoes for a variety of reasons, and it's been shown that if your doctor orders an echo, you already have a slightly higher probability of having pulmonary hypertension, of having heart failure, because whatever prompted your doctor to order the echo is probably a marker that you have more cardiovascular disease. So in order for us to make the recommendation that all patients with myeloproliferative neoplasms need to be screened with echo, it's premature, because that will require a study of enrolling all patients with myeloproliferative neoplasms and getting everyone screened for heart failure or pulmonary hypertension using an echo. And then after that study is done, then it will become more clear whether or not this recommendation can be made. And that is something that, is still ongoing, and we hope to do soon. And so and so this brings us to kind of like this non-thrombotic, the non-clotting complications of myeloproliferative neoplasms and myelofibrosis is kind of this complex web of heart failure and pulmonary hypertension, and pulmonary hypertension can beget heart failure, and heart failure can cause pulmonary hypertension. But no matter how you slice it, the evidence shows that if you have either pulmonary hypertension or heart failure, and you have an MPN, you're at a higher risk of death, you're higher risk of cardiovascular events, and there might be an association with a higher risk of disease progression as well, which kind of just begs the question of, how do we surveil, and like what other studies can be done to better understand this complex web. So this is a paper that will be coming out, but this is kind of our based on the literature. These are not like, guidelines or anything. This is just, expert consensus between myself and my collaborators. But essentially, we advocate for patients who have MPNs or at risk of having of PH, such as, if you're having shortness of breath, if you're having any leg swelling, should get screened with an echo. And then those patients with intermediate or high probability of pulmonary hypertension on echo should undergo a right heart catheterization. And then the treatment of pulmonary hypertension and heart failure, it really should be per the guidelines, because there's not enough evidence within the myeloproliferative population itself to suggest that different treatment strategies. But at least what we know is that this is very prevalent, and that this is something that should be kind of investigated if symptoms of heart failure and pulmonary hypertension arise. And so the last little bit, it was just to be kind of a general overview of how to keep your cardiovascular health. I just went on for half an hour talking about doom and gloom and, all these like scary things. But there are many things that you can do to kind of help your cardiovascular profile and help and keep you busy or keep you healthy. And so it's important to have a multidisciplinary approach. There's this new field of cardiology called cardio-oncology that kind of focuses cardiovascular care of patients with malignancy, including myelofibrosis and myeloproliferative neoplasms. And it's important to note that current guidelines do not take into account the history of MPN, which is something we're actively studying. So I adapted these slides from Dr. Feldman, who's a close colleague of mine in cardio. She's the director of cardio-oncology at Cornell. But one of the things that I like to think about is the ABC. So awareness, blood pressure control, cholesterol and cigarette, diet and diabetes, and exercise. So for awareness, obviously, you guys are doing by virtue of being at this talk and being engaged, you are raising your awareness and we're raising your own awareness. So continue to advocate for that and advocate for yourself is important. As far as aspirin, it's nuanced when it comes to myelofibrosis in particular. So I would defer that with a conversation between you and your hematologist. Blood pressure is always important. Studies been shown that the lower the blood pressure to a certain point, the lower your risk of cardiovascular disease. So generally recommend the goal of less than 130 to 80. And just keep in mind that the office visit blood pressure might be higher. And that if your blood pressures are at the office are always a little high, I would recommend considering buying a home blood pressure cuff where you can take it at home and you can keep a log and bring it to your cardiology office visits. It's very helpful. Um, and then that goes into cholesterol and cigarettes. Obviously, smoking is bad, and particularly with MPNs. There's a study out of Brigham and Women's led by Dr. Howe that showed that patients who smoke were at higher risk of dying from cardiovascular disease. With MPNs. As far as cholesterol, it's a little bit more nuanced. We recommend statins if you're high risk, if you've had prior heart attacks or strokes, and the LDL goal in general is less than 100 patient for primary prevention, and maybe lower to 70s, 55 for patients who've already had a heart attack or stroke. It's important to note that cholesterol in myeloproliferative neoplasms, like the exact cutoff, is unknown. Particularly, it's something that we're studying is that your LDL or your bad cholesterol may actually be low in myelofibrosis, lower than usual, because a lot of this like cell turnover you might have in your spleen or your bone marrow uses up a lot of the cholesterol, and so the LDL level might actually be lower. And whether or not that affects clotting or risk is it's up in the air and it's something that we don't know yet. But just sticking to the American Heart Association and American College of Cardiology guidelines for cholesterol management is the best that we have at this point. So I would recommend just talking to your doctors about your LDL goal and consider statins if they are indicated. Diabetes and diet also very important. Know your numbers. Just a caveat again for polycythemia vera, because you have a high turnover of red blood cells, your A1C may be artificially low. And so you just want to be aware of that if you have a risk for diabetes or you have diabetes, keeping a good log of your day-to-day blood glucose levels is important and worth bringing up to attention to your doctors. And then exercise is always recommended. If you have a history of heart failure, recent heart attack, there's also cardiac rehabilitation that is covered by insurance that has been beneficial in both of these disorders. So it's something that you can talk to your doctor about. So my take-home points are that myeloproliferative neoplasms are increased risk of cardiovascular disease. Patients with myelofibrosis are particularly high risk of heart failure and pulmonary hypertension, and working closely with your hematologist cardiologist is important to reduce this risk. And any symptoms of heart failure and pulmonary hypertension should prompt evaluation by your physician and referral to cardiology. And it's important to be empowered and to decrease your risk of cardiovascular disease. So thank you. This is my email in case anyone has any questions afterwards. I'm happy to answer. I'm over time a little bit, but I'm actually okay, so I can take like 5 minutes to answer any questions.
Great. That was super, super informative. So thank you for hopping on and doing this with us. I think I know I learned a ton, and I'm sure everyone else did as well. So now is the time to ask questions for Dr. Leiva. You can type those into the chat if you'd like to ask them. You can also unmute yourself if you'd like to ask verbally. Um, but I guess just to start us off while we're waiting for a question to come in from the audience, um, currently, do you know if there are any MPN patients, or I guess how often do you think MPN patients are recommended to see cardiologists? You mentioned this can be a little bit scary to listen to. And should these patients be seeking out a consultation with the cardiologist, do you think?
Yeah, it's always that type of like question is always interesting to me, especially because I trained and I have been training in large academic institutions that have cardio-oncologists, have cardiology, and a lot of the hematologists are aware of these risks and promptly refer patients. But out in the community, it's a little bit different. Obviously, it's and most of the cancer care in the United States is out in the community. So, what I would say is, I would at least if you're over the age of 50, at least see a cardiologist once a year and advocate to see one once a year at least. It's good practice in anyone anyways. It's at risk for heart disease, but particularly with MPNs. And if possible, a cardio-oncologist, which are very few and far between, but any cardiologist honestly would do, especially if you're high risk or you have symptoms.
Good to know. Right. And then we have a question coming in from the audience. This one's just asking if you have congestive heart failure, what's considered to be too low of a blood pressure, just so that they have an idea of what number to keep an eye out for.
Yeah, so that's a great question. So, that's something that we deal with a lot in my heart failure clinic. When we have patients with heart failure with reduced ejection fractions who are walking around with low blood pressures in the 80s over 60s, and as long as they're not having any symptoms from not passing out, that's okay. But other patients might be symptomatic at even lower or higher blood pressure, so like in the hundreds. So the way I really guide it is based on how you're feeling. If you feel lightheaded after taking your medications and you check your blood pressure and I would make a note of it. That's probably too low if you're feeling, lightheaded or passing out. But normally we like to keep the blood pressure lowish, with patients with heart failure, especially with reduced ejection fraction. But that's really individualized. So I start to get worried once the systolics are always in the 90s. And unless the patient's like, no, I feel great. I'm walking, I'm like, hiking and I'm not lightheaded, then I feel okay, like, continuing medications and like just like keep it a close eye. But if they're telling me, oh yeah, I get lightheaded when I stand up, or I almost fall because I feel lightheaded, then maybe that's a little too low. So it really depends on the symptoms.
Okay. And then next up, are there other cardio symptoms like flutter, PVC, PAC potential? Are those potential indicators of heart failure for ET and secondary myelofibrosis, or has research not
Yeah.
gotten there quite yet?
So that's a great question. So anytime we think about Flutter, PVCs, PACs, which are kind of like kind of more electrical things that go on in the heart, it's always difficult to say if it's chicken or the egg. So what I would say though is patients with atrial flutter PVCs tend to have a higher risk for heart failure, and whether or not that's because the PVCs themselves can cause the heart failure, unless you're having, a PVC burden of 10% is unlikely. But PVCs may mean that, your heart's just not structurally normal. Whether or not you actually have heart failure, that's more of the symptoms base, but any rhythm abnormality is definitely should be investigated. Doesn't necessarily mean you have a heart failure, but it means that your heart structurally may not be normal.
Okay. I think that's great. And I don't see any other questions in the chat currently. And I know that you need to go. So we're going to wrap up our questions. If you have any other questions for Dr. Leiva, he does have his email and he said that you are free to send him an email if you have a question. But I just wanted to thank you again for your time and hopping on and doing this with us today.
Awesome. Yeah, no, thanks for having me. And yeah, I'm happy to answer any questions I already know. Great. Thanks so much.
Awesome. Thank you. All right. And as we're wrapping up today, I wanted to highlight a couple upcoming events that we'll have for our myelofibrosis education. We will be doing a patient spotlight event. This will be the first one that we're doing for myelofibrosis. I'm working to set the date on that, but that'll be a really cool one to hear from a member of the community and about their experience. So highly recommend you be on the lookout for that one. And then I'm going to be recording this podcast next week, and this is going to be about CAR T cell therapy for myelofibrosis. This is a really exciting new development for myelofibrosis. This is really cool research going on. Um, so that'll be being recorded next week, and I'll try to get it released probably the week after. So be on the lookout for that as well. Um, and then as you leave today, if you could again take a moment to fill out that survey, it really does help us so that I know what types of events the community wants to see. Um, just thank you to everyone for joining today. I really do appreciate you spending your time with us and coming here to learn. So thank you all. If you would like to talk to me about either HealthTree or have any questions for me, or potentially want to speak with one another, I will go ahead and close the recording and the live stream, but I will keep this call open if anyone would like to stay on and talk for a couple of moments. So I just, you don't have to, but if that's something you're interested in, I'll be doing that. But if not, and you need to hop off, that's totally fine as well. And I thank you for your time. And let's see, help if I can find all my buttons.